everyone. I'm delighted to be joined by Dr. Ahmed here from the University of Chicago. Welcome, Osman.
Thank you.
So what we're hoping to do is to just have a discussion about venous thromboembolic disease management, the current status and the future steps. So Osman, welcome to Newport and BSIR.
Thank you, Narayan.
And so just tell us a little bit about what your practice is and what sort of areas that you as an interventional radiologist in Chicago cover in this field.
Sure, absolutely. Well, first of all, thanks for the invite to do this interview. And as mentioned, I'm an interventional radiologist in Chicago in the United States. And at an academic program, we sort of tend to, obviously, as you know, compartmentalize our practice a little bit, subspecialize. So I sort of categorize my practice into three big buckets currently. One is interventional oncology. The second is musculoskeletal interventions. And the third, as I think we'll talk about today, which is probably the biggest bucket, I think, is venous thromboembolism or VTE.
And so this field with VTE treatment, there's been quite a clear expansion in the scope of practice as interventionalists. And can you just give us a sort of brief sight into what we as interventional radiologists can offer in this field in both DVT and PE management?
Yeah, absolutely. I think as you've alluded to, just the scope of what we're doing in the field of VTE is expanding, tremendously. And I think that goes hand in hand with just development in industry and the products that we have available to us. I think, historically we started by just doing, plain old catheter-directed thrombolysis and really kind of had no other great options. And I think now, because of the tools, we can do a lot of different things. So we can start with things such as basic, just DVT, acute DVT interventions. But even within that, we've evolved, obviously, to thrombectomy and other, advanced interventions related to that, large bore thrombectomy as well. And then we've also, sort of moved on into pulmonary interventions. And then along with that, just chronic VTE interventions, which I think is also still sort of largely under-recognized and sort of still growing tremendously, and with those techniques such as recanalization and stenting and things like that.
Fantastic, thank you. And so with regards to pulmonary embolism management, these are often unwell patients. How did you set up your PE practice at the University of Chicago?
Yeah, absolutely. So so when I walked in, I had a tremendous amount of interest in this field, and I was fortunate that I trained at Stanford for my fellowship, and right at the time that the Perfect Registry had completed. And so I was sort of, I think at a ground level, very interested in this. And so I came with a lot of knowledge as well. And I took a very collaborative approach. Our interventional cardiologists actually do the pulmonary interventions as well. And we said, instead of sort of fighting each other, we said, well, let's work together. There's a lot of, interest and growth in this. And we essentially formed what's called the Comprehensive Venous Thromboembolism Program. And we have sort of co-directorship of that. And, I think, in that collaboration, we were able to really build a comprehensive program, because it really, sort of sounds corny, but it takes a village, to build a busy PE practice. You have to really build in pathways, and so we really protocolized everything, made sort of a pager that basically, essentially anyone that has a PE, gets notified through that pager and then sort of gets, triaged. And so, but that takes buy-in from multiple levels, because outside of us, the other people have to do their jobs too.
Yeah. And so, and you refer to those other people. I mean, who do you think are the key elements or key people, specialties, I guess, to be at the table to make a program like yours work successfully?
Yeah, absolutely. I think that the key stakeholders and getting them to buy in, again, so each specialty, I think, is a little bit unique in what it takes to get them to buy in. But I think the most important arguably are going to be your ER physicians, your diagnostic radiologists. And I think that's now really been significantly augmented by the advent of some of these AI companies, where you can sort of get imaging pushed directly to you. And then their ICU physicians as well. And so I think those three are key stakeholders. And again, each have a little bit different sort of role, obviously, in the triage and sort of recognition of this disease state. But getting them all sort of to buy in and work together, I think was the sort of primary challenge.
Thank you. And then when it comes to the actual technique of treating these patients, you alluded to things having moved on from catheter-directed thrombolysis. Can you give us a flavor of what the current, tools that we can use are, and maybe what the future could, hold in the next 5 years?
Yeah, absolutely. And I think we haven't necessarily maybe moved away from catheter-directed thrombolysis, but I think the emergence of other devices has really augmented our toolkit, our toolbox of what we can use and offer patients depending on their clinical status, their relative or absolute contraindication to lytic therapy as well. So, as you mentioned, really I think the significant sort of breakthroughs that have occurred really in the last 5 years with companies like Narayan and Penumbra with basically large bore suction thrombectomy to be able to evacuate these large chunks of clot in a single setting, which I think historically we never really were able to do well, and I think similarly, even on the CDT side, we're now also seeing sort of advancements with companies like obviously ECOS, which has been around for a while, but there's been some innovation there. Companies like Thrombolics, which are making sort of expandable cage to sort of improve surface contact. So we're seeing a lot better treatment options for our patients, and the ability to have multiple devices, I think, gives us a lot more flexibility and sort of opens a pool of patients we can treat as well.
Yeah, thank you. That's really helpful. And so, and just to dive into, these are unwell patients, and there's maybe a window of time to get them. How do you get your patients, screened and, into the lab in the right time and in the right status for you to do the interventions that you described?
Yeah, that's a great question. And I think that's really underscores the value of having a well-run PERT program, and really, again, the recognizing this disease as soon as possible, whether that's right at the time of imaging or right at the time of initial consults or evaluation by the ER docs, and sort of first knowing about the patient is sort of half the battle, I think, So once you figure that out, then, obviously you can activate your PERT team, whether that's your nurse practitioners or your residents or you yourself, going laying eyes on the patient and figuring out how unwell they are. As we risk stratified patients with PE into 3 primary categories: low, intermediate, and high risk. And then even the intermediates we sort of subcategorize. So really figuring out what category they fall into, and then sort of triaging from there appropriately.
Great, thank you. And again, from a patient perspective, it is true, unfortunately, that maybe there's not equal access to services. What can patients do to access the sort of advanced therapies, or seek a timely, appropriate help?
Yeah, that's a great question. I think I think about this a lot as well, because I think PE is one of those diseases we can probably put it in the same category as MI, stroke, things where once you have it, you set a go wherever you can, but similar to stroke, there's going to be a difference in the therapies that can be advanced or offered to you depending on where you go. And so I think really maybe more so the onus is on us as practitioners to educate sort of the other facilities that might not have these resources or capabilities, and say, look, if the patient is not well and doesn't have, can only get systemic thrombolysis at your institution, well, if they can be sort of transferred or whatever, stabilized, we could offer these therapies. So I think for us, at least, that was part of our initial program building, was going to the smaller sites around the city and saying, these are the therapies that we offer for your patients.
That's really helpful and really good advice. I mean, I guess it's much truer in America and the size of the geographically, but I guess it holds true in the UK and other centres where, there may be some distances between the presentation site and the site that offers the service. How do you establish a safe mode of practice where you have a hub and a spoke model to some degree? How have you done it in Chicago?
Yeah, that's a great question. I think obviously the key is education, and sort of, as we talked about, triaging patients. Sometimes patients are just not stable enough to be transferred, and so you do need those therapies like systemic TPA. There will always be a role for things like that. But again, through education and sort of saying, look, these patients, for example, in intermediate high risk, they may not need to be intervened on immediately, and instead of subjecting them to the risk of a systemic thrombolysis, you could theoretically stabilize that patient, transfer them. Similarly, we do things like that even within our own institution with ECMO, for example. Patient incredibly unstable, but once we get them on ECMO, that buys us some time. Then now we can go in and do our thrombectomy or other sort of advanced therapies.
Fantastic. And just finally, what does the future hold? What are we going to be doing in 5 years, which may be different to what we're doing now?
Yeah, that's the $1 million question, I think, which, I'm really excited. Yeah, this is one of the reasons why I think I'm super passionate about VTE, but specifically PE in general. I wouldn't say it's the Wild West, but it's still a time where we're really trying to figure out, do our procedures even work? And I think we have very important studies now, like PE Tract, which I think has started enrolling, which we're fortunate to be a site for, that will help answer the question of our therapies versus just plain old anticoagulation. And I think then beyond that, we really will get into all this exciting stuff of, well, what's the best way to treat our patients? What types of therapies? We have a million sort of devices now, it feels like, that we can treat our patients with, and try to figure out which is the right patient, which device for the right patient.
Yeah, fantastic. Osman, thank you so much for your time. It's been really exciting and insightful learning from your experience, and I hope you enjoy the rest of your conference.
My pleasure. Thank you so much.